During this presentation, we'll be talking about the neurological condition cerebral palsy.
Firstly, what is cerebral palsy and what does it mean? Cerebral refers to the brain and palsy refers to muscle weakness. So we are referring to a wide range of abnormalities occurring within our movement centers. These movement centers include the cerebrum, cerebellum, and basal ganglia. This condition is most common cause of neurodisability and can occur during prenatal, perinatal, or postnatal development. The causes are usually either environmental, referring to oxygen deprivation, trauma, or infection, or can be a mutant gene being passed on affecting the brain. The condition, however, will always impact a person's movement and posture. There are 5 main types of CP. Spastic CP is the most common, affecting 86% of diagnosed, and occurs when there is damage to the cerebral cortex and a lesion affecting the corticospinal tracts. The causes muscles to stiffen, limiting functionality, including the ability to talk. Spasticity encompasses hypertonic CP and has no known site of damage and is characterized by very low muscle tone. Dyskinetic CP affects 6% and includes dystonia and athetosis and arises with damage to the basal ganglia, causing a fluctuation in movements that are regular and slow. Dystonia refers to repeated twisting movements, and athetosis, slow movements in the limbs that are present during rest. Ataxic CP affects 5% and is caused by a lesion within the cerebellum, causing an interruption in muscle control, resulting in instability where movements appear jerky. And mixed CP is the final type and can be a combination of various types of abnormal movements. This is just a diagram to show you where the different types of CP can affect the movement centers. Firstly, spastic CP affecting the cerebral cortex, the outer grey matter layer. Dyskinetic CP affecting the basal ganglia. Ataxic CP down the bottom affecting the cerebellum, and mixed CP can affect any combination of movement centers, and as previously mentioned, there is no known site for hypertonic CP. With all the different areas of the brain affected, signs and symptoms can extend from a person being ambulatory to non-ambulatory, requiring postural support. Most commonly, CP is recognised when infants fail to achieve expected milestones in motor development. Postnatal signs often noticed are drooling, fisting, asymmetrical movements, poor feeding leading to constipation, delayed motor development, which could include but is not limited to inability to support head at 6 months, no smiling by 10 weeks, and not walking by 18 months.
Further to the identification of postnatal signs, there is an exhaustive list of symptoms often identified within the type of CP a person has: cognitive, somatosensory, visual, auditory, and speech deficits. Involuntary movements, abnormal posture and muscle tone if dyskinetic, and poor coordination, abnormal eye movements, and affected gait if ataxic. Nerve problems, stiff, weak muscles and tight-fisted if spastic, little ability to move, resistance to passive stretch, floppy muscle tone if hypertonic, and a combination of the above if mixed.
Depending on the damage to the brain, it can also extend to other neurological problems, including seizures, strokes, scoliosis, difficulty hearing, vision impairment, chronic pain, weakness and fatigue, epilepsy, and apraxia. As we have discussed, CP causes motor abnormalities due to brain trauma, but how does this trauma affect movement control? CP can cause a lack of muscle tone, muscle weakness, loss of selective movement, musculoskeletal problems, and postural control, and this can cause reduced range of movement and shortening of muscles, affecting gait and walking ability. In hypertonic CP, floppy muscle can prevent a person's movement altogether, leaving them with extreme limitation and non-ambulatory.
Affected lesions in the corticospinal tract can prevent muscle activation, limiting the ability to perform fine hand coordination and postural-related activities. Inadequate muscle contraction, making anti-gravity positions and bimanual tasks more challenging. Lack of head and trunk postural control, affecting an infant's primitive reflex and posture. And all these impairments can be present within a child with CP to a degree, resulting in limited movement. The overall goal of treatment of CP is to improve functionality and proficiencies towards independence. The treatment type depends on a person's specific symptoms and can include a combination of medication, therapy, and surgery to improve gait, balance, and communication skills. Botulinum toxin type A is the Botox used to prevent overactivity in muscles, and SDR is selective dorsal rhizotomy, which is cutting of sensory nerves to reduce the effects of spasticity. However promising, this is shown to be irreversible.
CP often reduces cardiorespiratory endurance and alters muscle tone, which leads to increased risk in chronic disease. Physical therapy programs aim to focus on improving aerobic capacity and muscular strength to develop gross motor function and lower cardiometabolic diseases. Exercise recommendation for CP includes single and multi-joint exercises at moderate to vigorous intensity and relate specifically to the patient, including step-ups, negotiating stairs, and cycling to build lower extremity strength.